Now coming to the IUI, the actual procedure. So here we will be talking of the consent, the timing of the IUI, the procedure per se, and whether this has got any complications. Procedure, again I am telling and repeating that the ART Act is giving you the consent forms for both husband insemination and donor insemination. Just go on their website, download those forms, print it on your letterhead, and start taking consent on those consent forms. Semen processing techniques I will be omitting because Dr. Kersi has covered it in great detail. Now let's come to the timing of insemination. The hypothesis why we are timing is based on the survival of the germ cells within the body. Sperms, they survive for 3 to 5 days, and ovum survives for 24 hours. And that is why we are doing IUI after 34 to 36 hours of our SCG trigger. If you are doing it by LH kit, then the LH surge can be detected in 36, the LH surge can be detected in serum in 36 hours before ovulation, and in urine, if you are doing by LH kit, 24 hours before ovulation. So if you are monitoring by LH kit, next day you do IUI. If you are doing by your follicle monitoring, 34 to 36 hours after your SCG injection. If you are using donor semen, and that has to be by default cryopreserved semen, remember cryopreserved sperms, they have a shorter lifespan than the fresh sperm. So accurate timing here makes more sense. So you have to be more careful. Now still there is controversy whether you should do IUI after 36 hours of SCG, or you should do IUI after documenting the ovulation, or you should do IUI along with your SCG injection. See, these are the three possibilities, and this is a debate. A 2010 systematic review of all the trials, they evaluated the effectiveness of different synchronization methods, which I talked in my earlier slide, in natural and stimulated cycles for IUI. And what they concluded? They concluded that your choice of doing IUI should be based on your hospital facilities, convenience for the patient, convenience of your medical staff, the cost incurred, and the dropout level, as no method of synchronization is superior to another. So what was our traditional thinking? IUI after 34 to 36 hours again is a guideline. This is a very interesting paper. I want all of you to pay attention because again we emphasize more on 34 to 36 hours. But sometimes it does happen. In my practice also, that patient has come from a very far off place. Sometimes they travel for 18 hours. So you can't tell them go back and come again after 36 hours or stay in Nagpur for 2 days. That is just not possible. So this paper will increase your confidence. What has they studied? They have studied the simultaneous SCG administration with your IUI. So same day, same visit, give SCG injection and do the IUI cycle, as the authors have concluded that there is no difference in the pregnancy rate when you are doing IUI after 34 to 36 hours or you are doing IUI with simultaneous SCG trigger. So remove all those hesitations from your mind, as the papers are saying you can time your IUI based on your convenience and your timing and the patient's convenience. But yes, guidelines are telling you to do it after 34 to 36 hours. So as far as possible, do follow the guidelines. Now coming to the insemination procedure. Deposition of sperms in the uterus at any point above the internal os is considered as intrauterine insemination. While the procedure is fairly straightforward, appropriate care and attention to detail is essential to achieve good and consistent results with IUI. So you have to give dorsal position. You have to follow the strict aseptic precautions. Don't take it lightly. Don't do it without aseptic precautions. Don't use any antiseptic solutions. Catheters we will discuss. Do it with minimum trauma, inject slowly, and we will discuss the inseminate volume. So what are the equipments you require? Of course, the prepared sperm sample, just a speculum. 1 cc sterile syringe with blunt cannula, but the embryologist, they give you the loaded syringe with the catheter. Now coming to the clinical tips. We will be discussing all these steps one by one. The role of cervical mucus aspiration, full bladder, whether you should do it under ultrasound guidance, what is the role of passive straightening of cervix, which catheter you should, what should be the volume of inseminate, what should be speed of your insemination, whether you should do 1 or 2 IUI in that same cycle. So this we have discussed, no antiseptics, clean the vulva, vagina and cervix with the normal saline. Once your embryologist has prepared the sample, it has to be maintained at 37 degrees centigrade in a tube warmer or in a feast. Identity of the semen sample has to be cross-checked, rechecked again and again. Waiting time between the loading of syringe and procedure should be avoided. I know we all have busy OPDs, but it does not mean that they have loaded the catheter and you are not getting time to do the IUI procedure. Procedure should be carried out ideally in your minor OT or similarly equipped room. And you have to wear cap, mask and take all aseptic precautions. Now whether you should do cervical mucus aspiration before doing IUI. So there was this study I found out that pregnancy rate increased when you did cervical mucus aspiration as to those group where you have not done cervical mucus aspiration. If on speculum you are seeing that there is a thick cervical mucus lying at the internal os, so it makes sense to remove that thick cervical mucus. So gently remove that thick cervical mucus before you inject your catheter. Now what is the role of passive uterine straightening? Ideally we do cusco speculum and we don't hold the cervix. That is the no trauma technique. But sometimes you are just not able to negotiate the internal os. In that case, we do apply non-traumatic Alice forceps, but we don't catch it. Okay? So just apply, don't catch it, and just give a slight traction so that uterus becomes straight. So that also comes under a traumatic technique. Because passive straightening of the cervix will really make your catheter insertion very, very easy and traumatic rather than struggling here and there and touching the uterine walls. Whether you should do IUI under ultrasound guidance. Like I have got that facility, so we do under ultrasound guidance, but you can't. Because your routine IUI catheters you can't see on ultrasound. If you want to do your IUI on ultrasound, you have to use the ET catheter. And ET catheters are costly as compared to IUI catheters. So always remember, whenever we are talking of role of ultrasound, you have to use the ET catheters, that is the embryo transfer catheters, if you want to see your catheter on ultrasound. Now coming to the choice of IUI catheter. So again, what we want to have in our IUI catheter, we want to have a catheter which will deposit the small volume without requiring a dead space in the injection system, should be easy to use, made of non-toxic material, should be semi-rigid. If it's too soft, you will not be able to go. If it's rigid, it will have a traumatic, it will be traumatic to the endometrial cavity. So we want a non-traumatic entry past the cervical canal, and it should provide mechanism to prevent the backflow, because that also we don't want. So there are many, many catheters which are available in the market. Rigid catheters, they have got their own advantages and disadvantages. Routinely, we don't prefer rigid catheter only in cases of difficult IUI, where you are not able to negotiate the internal os with your soft or semi-rigid cannulas. There you can take help of your rigid catheters. So company-wise, there are many catheters. Length-wise, there are many catheters, 11 centimeter, 15 centimeter, 17 centimeter. Don't go with 17 centimeter because then it becomes difficult for you to negotiate. It becomes too lengthy for you to negotiate. Go for the medium length cannulas. Procedure, as I said, give her lithotomy position, follow all antiseptic precautions, clean with normal saline. If there is thick cervical mucus at internal loss, of course remove that cervical mucus. Try to do IUI without holding the cervix, but if at all you have to hold it, just apply non-traumatic Alice forceps and just give a gentle traction. Don't catch the lock of your Alice forceps. Sperms are injected slowly, slightly below the fundus. Don't touch the fundus, just 1 centimeter below the fundus. In IUI, as you are not doing it under ultrasound guidance, so it is the experience. If you know the UCL, you can calculate how much your catheter has inserted inside, and there you can inject it slowly. Injection must be a deliberate act taking about 2 minutes to deliver 0.5 cc of your specimen. So you can see really it tests your patience. 0.5 cc, you have to inject it in 2 minutes. Because if you inject it too briskly, it will lead to cramping and myometrial contractions. Don't remove it too fast. You have injected it slowly and भक से निकाल लिया. ऐसा नहीं चलेगा. You have to remove it gently, taking 60 seconds. So your IUI is taking insertion 2 minutes, removal 60 seconds, preparing and everything. So at least you have to give 5 minutes per patient for your IUI procedure. After injecting the sperm, tell your patient to lie down for 15 minutes. That is more than enough for sperms to go to the follicle. No need to elevate the legs or give her head-low position in IUI. Now what you will be doing in cases of difficulties, because not all cases are so easy. So if you are finding it difficult to negotiate the cervix, you can apply the lock and you can pull it more. I mean, you can apply pressure. You can give full bladder, not too full, not too empty. Rather make it a habit to do your all IUIs in semi-full bladder. Again, it will give you passive straightening of the uterus. USG guided, yes. You can use rigid catheter. If you are expecting difficulty, you can take UCL in the follicular phase and you can note down the curvature. You can also do cervical dilatation on day 2 up to day 5 of the cycle. And in extremely difficult cases where you are just not able to negotiate, you can deposit these semen in the cervical canal or high in the posterior fornix. That is the thing you can do in IUI, which we can't do in IVF, because we can't deposit embryos there. But in extremely difficult cases, IUI can be deposited intracervical, intravaginal, high in posterior fornix, because the sperm will find its way. This is the $1 million question asked by everyone. What should be the rest? 15 minutes which we make them lie down is more than enough. After going home, we tell them, please, please do all your routine activities which you are doing before coming to us this day for getting your IUI done. I know many patients don't listen, but we quote the studies, we quote the literature, that this is the literature. You don't need bed rest, but if you want to take, I mean, you can take. What is the post-procedure care? You have to tell them that there will be increased wetness, because once they stand up, the seminal plasma will come out, so they should not feel, because they feel मेरे तो स्पर्म ही बाहर आ गए, मैं तो खड़े हो गई तो मैडम आपने डाला था वो सब बाहर आ गया. तो आपको उनको बताना है कि ऐसा नहीं है, स्पर्म्स जहाँ पहुँचना था पहुँच गए हैं, ये जो फ्लूइड है ये बाहर आया है. Some patients, they can have abdominal cramping or discomfort. Usually it occurs when the sperm wash is not done properly. If it has been done properly, she will not have, because of the seminal factor, she will not have the discomfort. But if it was a traumatic IUI, she might have some discomfort. Light bleeding or spotting, again in cases of traumatic IUI. Otherwise, routine IUI she won't have. Now again you have to tell them about the intercourse. We forgot to counsel them whether they should do intercourse or they should not do intercourse. Tell them they have to, rather they should do intercourse because it will increase your clinical pregnancy rate. So intercourse is perfectly allowed. You will be doing a urine pregnancy test after 2 weeks of IUI. And if you are giving SCG trigger, do tell them if she is doing the UPT, she will get positive in first 10 to 12 days because of your SCG trigger. Now whether you should do single or double IUI, now all the literature and consensus is in favor of single IUI, because they are saying that even if you are doing double IUI, it is only increasing the cost, but it is not increasing your clinical pregnancy rate. So you can do single IUI. But sometimes in cases of donor insemination, we can do double IUI, because if it is by husband insemination, they do intercourse and they compensate. But in donor insemination, as you are doing for azoospermia, you can think of doing 2 IUIs in that cycle. How many cycles? We have already discussed, not more than 4 for husband semen and not more than 6 for donor insemination. So in cases of IUI, when we are talking of success rate, it is the proper patient selection, which we have discussed in first talk. Appropriate stimulation protocol discussed in great length in my second talk. Good quality lab work, Dr. Kersi will be covering. Procedure we have covered in this talk.